Hello, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Professor Andrew Lotery from Southampton in England. Andrew, welcome to Retina Synthesis.
Thank you very much. It's lovely to be here. Thank you.
Uh, Andrew is one of the world's authorities on photodynamic therapy of central serous chorioretinopathy. Uh, Andrew, how do you evaluate a patient with suspected CSR?
So I'm interested in the duration of their symptoms, um, whether it's their first episode. I uh, interested in their age, um, and whether they've any history of recent stress or of taking steroids of any sort. Looking for clues about whether this is acute or chronic central serous chorioretinopathy, because that's going to affect my suggestions for treatment. Um, so yeah, so it starts really with a history, um, and I'm just looking for potential modifiable risk factors as well. Um, Often we find there is some evidence of having to take steroids, um, be it orally, creams, inhalers, injections into joints. That I don't think it's fully proven, but it seems to be a common risk factor in many patients. And then some patients have some very acute stress, sorts of things I start asking about. And then, of course, we do retinal imaging. Um, I'm interested in the autofluorescence images um, to see whether this is recurrent or not, to see if there's evidence of previous central serous chorioretinopathy, which the patient may not even be aware of if it's not affected. There hasn't been subfoveal fluid, and that again gives me a clue whether this might be a relapsing form of the condition or whether this is the first episode and perhaps maybe a one-off episode. So in my mind, I'm trying to look for uh, risk factors, and then I'm trying to decide, is this acute and should I just wait? If the and monitor. So if the patient doesn't seem to have CSCR for more than 4 months, I'll probably just watch them. We'd also do OCT angiography now, looking for any pachychoroid neovascularization, and of course OCT. And the other thing looking at is the choroidal thickness in both eyes, because often even in the asymptomatic eye, the choroid's thick in both eyes. If it's not, you kind of wonder, is this definitely central serous chorioretinopathy? So those are sort of the things that are going through my mind about whether just to observe the patient or to consider, whether we can offer therapy or not, which um, in our UK National Healthcare Service practice, we try to offer half-dose photodynamic laser therapy as treatment. We're also about to start a clinical trial, a randomized placebo-controlled clinical trial of half-dose photodynamic laser therapy, because that hasn't really been done for a year's follow-up, and that's just going through final ethical approval to get, and it's been funded by our NIHR funding body. So that will be starting soon.
What about fluorescein and indocyanine green angiography in these patients?
So we do that um, I think they can be helpful, and particularly we'd do those tests certainly before doing photodynamic laser therapy, the guide therapy. We're looking for a leak on the fluorescein angiogram. We're looking for increased cyanescence, and that will guide our treatment. However, in the initial presentation, if I'm very confident of the diagnosis based on OCT and OCTA and autofluorescence, from a practical point of view, we don't do that initially, and we would monitor really with OCT initially. And if things are improving, we wouldn't rush to that. It's obviously these tests are invasive. Occasional risk factors, very rarely anaphylaxis. But with the advent of OCT angiography, we don't initially do fluorescein angiography, ICG angiography, but that's a pragmatic way of looking things in a socialized healthcare system. If we've got some concerns, or maybe another diagnosis, polypoidal choroidal vasculopathy, for example, or we're trying to, we could certainly do those tests. Often the challenge comes in patients who are maybe in their 60s, and you're trying to decide, is this wet AMD? Is this central serous chorioretinopathy? And sometimes it can be quite difficult. There's sort of an overlap in the typical age where people develop choroidal neovascularization from age-related macular degeneration and central serous chorioretinopathy. So of course we're looking for other features that might point to this being wet age-related macular degeneration, presence of drusen, for example. So I guess my thought process is this typical central serous chorioretinopathy? Could it be a phenocopy of age-related macular degeneration? Is it acute or chronic? Is there previous episodes present particularly on autofluorescence? Gravitational tracts, of course, are very typical. So getting the disease right and then deciding on the possible treatment based on all these things running through my mind when I see a patient.
So what are the indications for photodynamic therapy, just to review that once again?
Yeah, so a patient who's present, I would say present of subfoveal fluid more than 4 months. If you have some, if you've had some retinal imaging over that 4 months that's showing that there's a significant reduction in fluid, then you might hold off longer than that. But presence of active central serous chorioretinopathy, we tend to reserve it for patients who have subfoveal fluid and who have some reduction of visual acuity. Unfortunately, at the moment in the United Kingdom, there is a national shortage of verteporfin, which means that we've had to bring in some more stringent visual acuity requirements. So patients' vision has to be 20/40 or worse with their standard glasses that they're wearing, i.e. affecting their driving level vision legally, so that we've had to sort of stratify and because there's a very limited supply of the drug at the moment, and that's likely to be for the next year or so. But if we didn't have that restriction, we'd treat people with better visual acuity than that, so maybe 20/30 or worse. Just for anybody who's thinking of doing a clinical trial of central serous retinopathy, just something that we learned from our pleuronome trial is that, of course, you have an entry criteria for visual acuity, but when you do a clinical trial refraction, you can significantly improve the visual acuity. But the old way to treat this, of course, is just adding a half a diopter plus lens, and that could improve visual acuity. So you can refract patients out of the visual acuity criteria you set for your trial. And so for our upcoming trial of PDT, we're using their best reading visual acuity as the entry criteria, and then we'll use best corrected visual acuity later on in the trial. But because that's more representative of their real world visual deficit, because of the subfoveal fluid. So yeah, it's the patient symptomatic with subfoveal fluid that's been present more than 4 months and isn't showing signs of improving.
What's the technique in terms of infusion and laser treatment?
So we do half dose verteporphyrin. You can do half fluence as well, but essentially, uh, patient is dose is calculated based on patient's weight and height. The drug is infused over 10 minutes intravenously, and then 5 minutes later, we apply the laser treatment for 83 seconds, and it's with a you look at the fluorescein ICG angiogram. You want to treat really the areas of hypercyanescence, ideally with a 500 micron border either side, so add 1,000 to the linear dimension. We avoid treating over the optic nerve because the original animal experiments showed you could infarct the optic nerve. It's actually in the license for the drug not to treat over the optic nerve. I know some colleagues do and say it's fine, but I'm nervous of that, so we'd keep a 200 micron border off the optic nerve. So yeah, and it's applying, I think it's 50 millijoules. I'll have to check exactly, remind myself, but it's I know some colleagues do half fluence, however, which gives the same amount of energy delivered, but there's an increased risk of photosensitivity if you do that, and more likely to get sunburn, for example, if you're giving the full drug volume, as opposed and then reducing the fluence of the laser, whereas with half dose, I think you're less likely to get complications such as photosensitivity. Both give the same amount of energy, but I think half dose makes sense for being a little bit safer.
So half dose, full fluence.
Yes, yes.
What contact lens do you use to administer the laser?
We use area centralis, and if you can't cover the whole lesion, or if you've got with one application, you can, after you've delivered the laser, you can reset it and immediately reapply to the areas you haven't treated. So I typically print out the fluorescein ICG image from the patient and take it into the laser room with me and have it right beside me, turned upside down, so it's the right orientation, so I can align with the patient's blood vessels, retinal blood vessels, and know exactly where I'm where I want to treat it. I just, I mean, you can obviously have it projected on a computer, but it's just easier to have it print out at the laser when you're doing this. And if you have two eyes to treat, you can of course reset the laser after you've treated the first eye and go over and treat the second eye immediately afterwards. So you can treat two eyes in the same visit. The other thing we do is that we group patients. We have a list of 3 or 4 patients. As I say, there's a limit. There's a restricted number of vials available, and we can, and by doing that we can treat more than one patient per vial. Because it depends on the height and weight, how much is needed. So you can open it up, and as long as you're treating everybody within a few hours, you can make one vial, perhaps treat 2 patients. So we weigh everybody before the laser session and make sure we have enough vials to cover the number of patients.
What's the follow-up?
So we like to see them maybe about a month afterwards, just about, because there won't be an instant recovery. You're turning off the tap, but the bath water has to drain out of the eye, the subretinal fluid. So I think you have a pretty good idea if it's been successful. A 1 month review, and that would be typical. I think the more chronic lesions, the ones where there's perhaps not a lot of fluid, there's where there is some atrophy of neurosensory retina. They're the ones that are least likely to respond. If there's just a sliver of fluid, it's been there for a long time, there's some atrophy, maybe reduced autofluorescence of the RPE, and then these are potential features that they won't respond so well in terms of visual acuity improvement. So the more chronic, I think, the more guarded the prognosis. But yeah, I mean, a large, certainly structurally, a very large percentage of patients show significant improvements, I would say, by 1 month.
How many patients need more than one treatment?
So it does work on repeated treatment. It's probably 20–30% of patients, I would say, have retreat treatment. I mean, I think I've treated some patients 3 times, maybe 1 or 2, 4 times. The majority would be just 2 treatments. I guess it depends on your patient population. But a large percentage, it's 1 treatment and there's either stable indefinitely or for many years.
Let's talk about the clinical trials, the PLACE trial. Tell us
Yeah.
about that.
So the PLACE trial, that was an open label study led by Camille Boone in the Netherlands, and that was a sort of pragmatic, randomized prospective study that compared photodynamic therapy to micropulse laser. And the primary endpoint, I think, was after about 7 to 8 weeks, and it was a structural endpoint in terms of looking at resolution of subretinal fluid. And it found that that primary endpoint, that there was significantly less subretinal fluid in the photodynamic group versus the micropulse group. And then patients had a final follow-up about 7 or 8 months after baseline. It was, as I say, it was pragmatic, so not exactly the same time for each patient. And again, I think they maintained a reduction in subretinal fluid in the photodynamic group over the micropulse group. The visual acuity, there was only a couple of letters difference between the two groups at the 7 to 8 month endpoint. So it wasn't significant for best corrected visual acuity in terms of just detecting a difference between micropulse and PDT, but it did detect a structural difference at 7 to 8 weeks for subretinal fluid.
What's the upcoming paint trial going to be like?
So it's similar to our VICI study in terms of the study design, in that it's a randomized placebo-controlled trial of half-dose verteporfin versus control. It's going to have 140, hopefully at least probably about 130 participants, randomized equally to each group. It's going to be a 1 year follow-up with assessment every 4 months. There is rescue treatment, so if patients are not doing well, like they can, and this is something that we had also in the VICI study of eplerenone, they can have rescue therapy with PDT, half-dose PDT. Interestingly, in the previous study, very few patients did meet the criteria for rescue, and so didn't have it. There's only a few participants in the VICI trial, but it's a 1 year randomized controlled trial. So they all participants will have a PDT laser procedure, but half of them will, rather than receiving verteporfin, they'll receive dextrose solution as the infusion. They'll be masked to what they're receiving, and the person giving the laser, their arm will go through a drape, and they won't see that what's been infused, because the verteporfin's a greenish color, so they won't know, but they will. The laser light will be applied in each group, and then they'll be reassessed at 4 and 8, and then final endpoint 12 months. And if there's significant subfoveal fluid, they can be retreated at the 4 and 8 month time points within their groups.
What's the criteria for rescue?
So it's a drop of visual acuity, I think, of 10 letters. So 2 lines drop in vision, plus presence of at least 50 microns subfoveal fluid in the eye.
So in the past, there has been use of mineralocorticoid receptor antagonists like spironolactone. What's the current verdict on those agents?
Well, our randomized placebo-controlled trial of eplerenone, which is a selective mineralocorticoid receptor antagonist, showed absolutely no benefit with eplerenone, and indeed, in terms of some structural outcomes, there was less subretinal fluid, less choroidal thickness in the placebo group at 12 months compared to the eplerenone group. So we saw no benefit. Our primary endpoint was best corrected visual acuity, and there was I think 1.73 letters difference between the two groups, and that wasn't statistically significant. There was no statistical difference in low luminance visual acuity, and some of the structural outcomes actually were significantly better for the placebo group. So we saw no evidence of eplerenone a mineralocorticoid receptor antagonist working, and we chose that over spironolactone because it was more specific to mineralocorticoid receptor antagonism. It had less side effects such as gynecomastia, and we didn't think we could convince predominantly male population to take spironolactone. So we haven't done a study for spironolactone, but we just don't feel there's compelling evidence to do so based on the Vici study. Now there was lots of we did a meta-analysis of all the studies of eplerenone as well, and there, there's lots of short-term studies. There's lots of retrospective studies. Most of the studies we looked at were, had some limitations. They hadn't pre-specified they hadn't pre-published their statistical analysis plan. They're retrospective in nature, no control groups, and so we felt our results were consistent, actually, in particular for our primary endpoint of best corrected visual acuity, that the other studies hadn't really demonstrated an improvement in visual acuity either. So there can be side effects with eplerenone, such as hyperkalemia. So we don't think it should be used at all based on the Vici study. I think that the huge challenge with any study in central serous retinopathy is that it is a relapsing condition, and you can if you don't have a control group, you can convince yourself that your therapy works just because the disease can get better on its own, with nothing. And if you don't have a control group, there are so many case reports of multiple different therapies, but it can be really difficult to know what the ground truth is if you don't have a control group. The visual acuity improved in the Vici trial in both the placebo and the control arm. So it was a couple of letters better from after a year in both groups. But if we hadn't had a control group, we might have said that was because of the treatment, and it clearly wasn't, because it got better in both groups. So it's difficult disease to study, I think, because of that. It can spontaneously improve.
What about NSAIDs?
Well, I think that's just one of the many things that have been suggested, but as I say, I haven't seen I'm not aware of a good study with appropriate controls to really convince me that they work. I think anecdotally, I think there is certainly I think that the consensus would be that photodynamic therapy is effective at structural resolution of fluid. How much that translates to functional benefit versus control, I don't think it's been really demonstrated yet. We are going to do microperimetry as well, as an exploratory endpoint in the paint trial. Not every center has microperimetry, but we will be trying to look at that as well as another functional endpoint as well. But I don't think for NSAIDs it's really been shown that they're effective, and I think people, you can suggest H2 blockers, you can suggest melatonin, all of these things have been eradicating H. pylori, all the things have been postulated, but the evidence of a proper clinical trial is, I think, lacking for most of them.
Well, this was a wonderful discussion. Thank you so much, Andrew.
It's a
And
pleasure.
we'll be back with you after the paint trial is
Yeah,
complete.
I'd love to come back and tell you the results of that.
Great. Thank you so much.
Thank you.